Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing articles from Journal of American Medical Association, Hypertension and Kidney Function after Living Kidney Donation. Objective: to determine the risk of hypertension in normotensive adults who donated a kidney compared with non-donors of similar baseline health. Their rates of estimated glomerular filtration rate, eGFR, decline, and risk of albuminuria were also compared. Design, setting, and participants' prospective cohort study of 924 standard criteria living kidney donors enrolled before surgery and a concurrent sample of 396 non-donors. Recruitment occurred from 2004 to 2014 from 17 transplant centers, 12 in Canada and 5 in Australia. Follow-up occurred until November 2021. Donors and non-donors had the same annual schedule of follow-up assessments. Inverse probability of treatment weighting on a propensity score was used to balance donors and non-donors on baseline characteristics. Exposure living kidney donation. Main outcomes and measures: hypertension, systolic blood pressure, SBP, greater than or equal to 140 mmHg, diastolic blood pressure, DBP, greater than or equal to 90 mmHg, or antihypertensive medication, annualized change in eGFR, starting 12 months after donation/simulated donation date in non-donors, and albuminuria, albumin to creatinine ratio greater than or equal to 3 mg/ml, greater than or equal to 30 mg/g. Results: among the 924 donors, 66% were female. They had a mean age of 47 years, and a mean eGFR of 100 ml per minute/1.73 square meters. Donors were more likely than non-donors to have a family history of kidney failure. 464,922, 50%, versus 89,394, 23% respectively. After statistical weighting, the sample of non-donors increased to 928, and baseline characteristics were similar between the two groups. During a median follow-up of 7.3 years, IQR 6.0 to 9.0, in weighted analysis, hypertension occurred in 161 of 924 donors, 17%, and 158 of 928 non-donors, 17%. Weighted hazard ratio 1.11, 95% CI 0.75 to 1.66. The longitudinal change in mean blood pressure was similar in donors and non-donors. After the initial drop in donors' eGFR after nephrectomy, mean 32 ml per minute/1.73 square meters, donors had a 1.4 ml per minute/1.73 square meters, 95% CI, 1.2 to 1.5 per year lesser decline in eGFR than non-donors. However, more donors than non-donors had an eGFR between 30 and 60 ml per minute/1.73 square meters at least once in follow-up. 438,924, 47%, versus 49,928, 5%. Albuminuria occurred in 132 of 905 donors, 15%, and 95 of 904 non-donors, 11%. Weighted hazard ratio 1.46, 95% CI, 0.97 to 2.21. The weighted between group difference in the albumin to creatinine ratio was 1.02, 95% CI, 0.88 to 1.19. Conclusions and relevance. In this cohort study of living kidney donors and non-donors with the same follow-up schedule, the risks of hypertension and albuminuria were not significantly different. After the initial drop in eGFR from nephrectomy, donors had a slower mean rate of eGFR decline than non-donors, but were more likely to have an eGFR between 30 and 60 ml per minute/1.73 square meters at least once in follow-up. Hypertension and kidney function after living kidney donation. Objective: to determine the risk of hypertension in normotensive adults who donated a kidney compared with non-donors of similar baseline health. Their rates of estimated glomerular filtration rate, eGFR, decline, and risk of albuminuria were also compared. Design, setting, and participants' prospective cohort study of 924 standard criteria living kidney donors enrolled before surgery and a concurrent sample of 396 non-donors. Recruitment occurred from 2004 to 2014 from 17 transplant centers, 12 in Canada and 5 in Australia. Follow-up occurred until November 2021. Donors and non-donors had the same annual schedule of follow-up assessments. Inverse probability of treatment weighting on a propensity score was used to balance donors and non-donors on baseline characteristics. Exposure living kidney donation. Main outcomes and measures: hypertension, systolic blood pressure, SBP, greater than or equal to 140 mmHg, diastolic blood pressure, DBP, greater than or equal to 90 mmHg, or antihypertensive medication, annualized change in eGFR, starting 12 months after donation/simulated donation date in non-donors, and albuminuria, albumin to creatinine ratio greater than or equal to 3 mg/ml, greater than or equal to 30 mg/g. Results among the 924 donors. 66% were female. They had a mean age of 47 years and a mean eGFR of 100 milliliters per minute/1.73 square meters. Donors were more likely than non-donors to have a family history of kidney failure. 464,922, 50%, versus 89,394, 23% respectively. After statistical weighting, the sample of non-donors increased to 928, and baseline characteristics were similar between the two groups. During a median follow-up of 7.3 years, IQR 6.0 to 9.0, in weighted analysis, hypertension occurred in 161 of 924 donors, 17%, and 158 of 928 non-donors, 17%. Weighted hazard ratio 1.11, 95% CI, 0.75 to 1.66. The longitudinal change in mean blood pressure was similar in donors and non-donors. After the initial drop in donors' eGFR after nephrectomy, mean 32 milliliters per minute/1.73 square meters, donors had a 1.4 milliliter per minute/1.73 square meters, 95% CI, 1.2 to 1.5 per year lesser decline in eGFR than non-donors. However, more donors than non-donors had an eGFR between 30 and 60 milliliters per minute/1.73 square meters at least once in follow-up. 438,924, 47%, versus 49,928, 5%. Albuminuria occurred in 132 of 905 donors, 15%, and 95 of 904 non-donors, 11%. Weighted hazard ratio 1.46, 95% CI, 0.97 to 2.21. The weighted between group difference in the albumin to creatinine ratio was 1.02, 95% CI, 0.88 to 1.19. Conclusions and relevance. In this cohort study of living kidney donors and non-donors with the same follow-up schedule, the risks of hypertension and albuminuria were not significantly different. After the initial drop in eGFR from nephrectomy, donors had a slower mean rate of eGFR decline than non-donors, but were more likely to have an eGFR between 30 and 60 milliliters per minute/1.73 square meters at least once in follow-up. Next, we will be discussing articles from Annals of Internal Medicine. Association between autoimmune diseases and monoclonal gammopathy of undetermined significance. Background. Monoclonal gammopathy of undetermined significance, MGUS, is a precursor of multiple myeloma, MM, and related conditions. In previous registry-based, retrospective studies, autoimmune diseases have been associated with MGUS. However, these studies were not based on a screened population and are therefore prone to ascertainment bias. Objective: to examine whether Megeus is associated with autoimmune diseases. Design: a cross-sectional study within I-STOPM. Iceland screens, treats, or prevents MM, a prospective, population-based screening study of Megeus. Setting: Icelandic population of adults aged 40 years or older. Patients: 75,422 persons screened for Megeus. Measurements: Poisson regression for prevalence ratios, PRs, of Megeus among persons with or without an autoimmune disease, adjusted for age and sex. Results: a total of 10,818 participants had an autoimmune disorder, of whom 599 had Megeus, 61 with a prior clinical diagnosis, and 538 diagnosed at study screening or evaluation. A diagnosis of an autoimmune disease was not associated with Megeus, PR, 1.05, 95% CI, 0.97 to 1.15. However, autoimmune disease diagnoses were associated with a prior clinical diagnosis of Megeus, PR, 2.11, CI, 1.64 to 2.70. Limitation: registry data were used to gather information on autoimmune diseases, and the homogeneity of the Icelandic population may limit the generalizability of these results. Conclusion: the study did not find an association between autoimmune disease and Megeus in a systematically screened population. Previous studies not done in systematically screened populations have likely been subject to ascertainment bias. The findings indicate that recommendations to routinely screen patients with autoimmune disease for Megeus may not be warranted. Artificial Intelligence for Real-Time Prediction of the Histology of Colorectal Polyps by General Endoscopists. Background: real-time prediction of histologic features of small colorectal polyps may prevent resection and/or pathologic evaluation, and therefore decrease colonoscopy costs. Previous studies showed that computer-aided diagnosis, CAD/CAS, was highly accurate, though it did not outperform expert endoscopists. Objective: to assess the diagnostic performance of histologic predictions by general endoscopists before and after assistance from CAD/CAS in a real-life setting. Design: prospective, multicenter, single-group study. ClinicalTrials.gov, NCT 044376115. Setting: 6 centers across the United States. Participants: 1,250. 2 consecutive patients undergoing colonoscopy and 49 general endoscopists with variable experience in real-time prediction of polyp histologic features. Intervention: real-time use of CAD/CAS during routine colonoscopy. Measurements: this is primary endpoints were the sensitivity and specificity of CAD/CAS unassisted and CAD/CAS assisted histologic predictions for adenomas measuring 5 mm or less. For clinical purposes, additional estimates according to location and confidence level were provided. Results: the CAD/CAS device made a diagnosis for 2,695 polyps measuring 5 mm or less, 96%, in 1,252 patients. There was no difference in sensitivity between the unassisted and assisted groups, 90.7% versus 90.8%, p equals 0.52. Specificity was higher in the CAD/CAS assisted group, 59.5% versus 64.7%, p less than 0.001. Among all 2,695 polyps, measuring 5 mm or less, 88.2% and 86.1%, p less than 0.001, in the CAD/CAS assisted and unassisted groups, respectively, could be resected and discarded without pathologic evaluation. Among 743 rectosigmoid polyps, measuring 5 mm or less, 49.5% and 47.9%, p less than 0.001, in the CAD/CAS assisted and unassisted groups, respectively, could be left in situ without resection. Limitation: decision-making based on CAD/CAS might differ outside a clinical trial. Conclusion: CAD/CAS assistance did not result in increased sensitivity of optical diagnosis. Despite a slight increase, the specificity of CAD/CAS assisted diagnosis remained suboptimal. Next, we will be discussing articles from British Medical Journal. Epidural analgesia during labor and severe maternal morbidity. Objectives: to determine the effect of labor epidural on severe maternal morbidity, SMM, and to explore whether this effect might be greater in women with a medical indication for epidural analgesia during labor, or with preterm labor. Design population-based study. Setting all NHS hospitals in Scotland. Participants 567, 216 women in labor. At 24, plus 0 to 42, plus 6 weeks gestation between January 1, 2007, and December 31, 2019, delivering vaginally, or through unplanned cesarean section. Main outcome measures. The primary outcome was SMM, defined as the presence of greater than or equal to one of 21 conditions used by the U.S. Centers for Disease Control and Prevention, CDC, as criteria for SMM, or a critical care admission, with either occurring at any point from date of delivery to 42 days postpartum, described as SMM. Secondary outcomes included a composite of greater than or equal to one of the 21 CDC conditions and critical care admission, SMM, plus critical care admission, and respiratory morbidity. Results of the 567, 216 women, 125,024, 22.0%, had epidural analgesia during labor. SMM occurred in 2,412 women, 4.3 per 1,000 births, 95% confidence interval, CI, 4.1 to 4.4. Epidural analgesia was associated with a reduction in SMM, adjusted relative risk, 0.65, 95%, CI 0.50 to 0.85, SMM plus critical care admission, 0.46, 0.29 to 0.73, and respiratory morbidity, 0.42, 0.16 to 1.15, although the last of these was underpowered and had wide confidence intervals. Greater risk reductions in SMM were detected among women with a medical indication for epidural analgesia, 0.50, 0.34 to 0.72, compared with those with no such indication, 0.67, 0.43 to 1.03, p less than 0.001 for difference. More marked reductions in SMM were seen in women delivering preterm, 0.53, 0.37 to 0.76, compared with those delivering at term or post-term, 1.09, 0.98 to 1.21, p less than 0.001 for difference. The observed reduced risk of SMM with epidural analgesia was increasingly noticeable as gestational age at birth decreased in the whole cohort and in women with a medical indication for epidural analgesia. Conclusion: epidural analgesia during labor was associated with a 35% reduction in SMM and showed a more pronounced effect in women with medical indications for epidural analgesia and with preterm births. Expanding access to epidural analgesia for all women during labor, and particularly for those at greatest risk, could improve maternal health. Next, we will be discussing articles from Clinical Gastroenterology. Older patients with acute on chronic liver failure have a higher waitlist mortality, but acceptable post-liver transplantation survival when compared to younger patients. Background and aims. There is a paucity of studies on older patients, greater than or equal to 65 years, who develop acute on chronic liver failure, ACLF. The objectives of our study were to determine clinical characteristics and outcomes of older patients listed for liver transplantation, LT, methods. Adults listed for LT with estimated ACLF, EST-ACLF, between 2005 and 2021 were identified using the United Network for Organ Sharing database and subdivided into older and younger age, 18 to 64 years, groups. Kaplan-Meier survival analyses were used to evaluate survival, and a competing risk model, fine gray, was used to evaluate risk factors for survival on the waitlist. Logistic regression was done to evaluate risk factors. Results: a total of 4,313 older, 14%, and 26,628 younger, 86%. Patients were listed for LT, and 2,142, 49.6%, and 16,931, 63.5%, were transplanted, respectively. Older patients had a higher 30-day waitlist mortality than younger patients, 20.4% versus 16.7%, p less than 0.0001. This was more pronounced in Est ACLF2, 23.7% versus 14.8%, p less than 0.0001, and Est ACLF3, 43.3% versus 29.9%, p less than 0.0001. 1 year post-LT, patient survival in older patients with Est ACLF grades 1, 2 and 3 were 86.4%, 85.5%, and 77% respectively. Younger patients had better survival across all Est ACLF grades. When adjusted for transplant eras, respiratory failure was the only independent risk factor for increased 1 year post-LT mortality in older patients. Conclusion: older patients with Est CLF had significantly higher waitlist mortality than younger patients, but had acceptable 1 year post-LT survival, including those with Est ACLF3. Therefore, age alone should not be considered as a contraindication for LT. Older patients with respiratory failure should be carefully selected for LT. Prolonged gastrointestinal manifestations after recovery from COVID-19. Background and aims. Acute enteric infections are well known to result in long-term gastrointestinal (GI) disorders. Although COVID-19 is principally a respiratory illness, it demonstrates significant GI tropism, possibly predisposing to prolonged gut manifestations. We aimed to examine the long-term GI impact of hospitalization with COVID-19. Methods. Nested within a large-scale observational cohort study of patients hospitalized with COVID-19 across North America, we performed a follow-up survey of 530 survivors, 12 to 18 months later, to assess for persistent GI symptoms and their severity, and for the development of disorders of gut-brain interaction, DGBIs. Eligible patients were identified at the study site level and surveyed electronically. The survey instrument included the Rome-4 Diagnostic Questionnaire for DGBI, a rating scale of 24 COVID-related symptoms, the Gastrointestinal Symptoms Rating Scale, and the Impact of Events Revised Trauma Symptom Questionnaire, a measure of post-traumatic stress associated with the illness experience. A regression analysis was performed to explore the factors associated with GI symptom severity at follow-up. Results. Of the 530 invited patients, 116 responded, 52.6% females, mean age, 55.2 years, and 73 of those, 60.3%, met criteria for 1 or more Rome-4 DGBI at follow-up, higher than the prevalence in the U.S. general population, p less than 0.0001. Among patients who experienced COVID-related GI symptoms during the index hospitalization, abdominal pain, nausea, vomiting, or diarrhea, 42.1% retained at least one of these symptoms at follow-up. In comparison, 89.8% of respondents retained any GI or non-GI COVID-related symptom. The number of moderate or severe GI symptoms experienced during the initial COVID-19 illness by self-report correlated with the development of DGBI and severity of GI symptoms at follow-up. Post-traumatic stress disorder, Impact of Events Revised score greater than or equal to 33, related to the COVID-19 illness experience, was identified in 41.4% of respondents, and those individuals had higher DGBI prevalence and GI symptom severity. Regression analysis revealed that higher psychological trauma score, Impact of Events Revised, was the strongest predictor of GI symptom severity at follow-up. Conclusions. In this follow-up survey of patients 12 to 18 months after hospitalization with COVID-19, there was a high prevalence of DGBIs and persistent GI symptoms. Prolonged GI manifestations were associated with the severity of GI symptoms during hospitalization and with the degree of psychological trauma related to the illness experience. Next, we will be discussing articles from Clinical Infectious Diseases. External validation of the 2023 Duke International Society for Cardiovascular Infectious Diseases, Diagnostic Criteria for Infective Endocarditis. Background. The 2023 Duke International Society of Cardiovascular Infectious Diseases, ISCVID, criteria for infective endocarditis, IE, were introduced to improve classification of IE for research and clinical purposes. External validation studies are required. Methods. We studied consecutive patients with suspected IE, referred to the IE team of Amsterdam University Medical Center, from October 2016 to March 2021. An international expert panel independently reviewed case summaries and assigned a final diagnosis of IE or not IE, which served as the reference standard to which the definite Duke ISCVID classifications were compared. We also evaluated accuracy when excluding cardiac surgical and pathologic data, clinical criteria. Finally, we compared the 2023 Duke ISCVID with the 2000 modified Duke criteria and the 2015 and 2023 European Society of Cardiology, ESCAPE, criteria. Results. A total of 595 consecutive patients with suspected IE were included. 399, 67%, were adjudicated as having IE, 111, 19%, had prosthetic valve IE, and 48.8% had a cardiac implantable electronic device IE. The 2023 Duke ISCVID criteria were more sensitive than either the modified Duke or 2015 ESCAPE criteria, 84.2% versus 74.9% and 80% respectively, p less than 0.001, without significant loss of specificity. The 2023 Duke ISCVID criteria were similarly sensitive but more specific than the 2023 ESCAPE criteria, 94% versus 82%, p less than 0.001. The same pattern was seen for the clinical criteria, excluding surgical/pathologic results. New modifications in the 2023 Duke ISCVID criteria related to major microbiological and imaging criteria had the most impact. Conclusions. The 2023 Duke ISCVID criteria represent a significant advance in the diagnostic classification of patients with suspected IE. Next, we will be discussing articles from Journal of Clinical Rheumatology. Rheumatology High Blood Pressure Protocol reduces disparities, but delays remain for external primary care. Background/objective. To address high blood pressure, BP, in rheumatology patients, we previously implemented BP Connect, a brief staff-driven protocol to address high BP. Although timely follow-up and hypertension rates improved for patients with in-system primary care, PC, many receive PC and rheumatology care in separate health systems. In this cohort study, we compared rates of timely PC follow-up for high BP across System Health Maintenance Organizations, HMOs, before and after BP Connect implementation. Methods. All adult patients with high rheumatology clinic BP and PC in that HMO were eligible. BP Connect's protocol engaged the staff in remeasuring high BP greater than or equal to 140/90 mm Hg, advising cardiovascular disease risk, and connecting timely PC follow-up, which for patients with PC across system includes written follow-up instructions. After an eligible rheumatology visit, the next HMO PC visit with BP was used to determine rates and odds of timely follow-up before and after using multivariable logistic regression. Results. Across 1,327 rheumatology visits with high BP and across system PC, 2013 to 2019, 951 occurred after 2015 BP Connect implementation. 400 had confirmed high BP. Primary care follow-up rose from 20.5% to 23.5%. The odds of timely PC-BP follow-up insignificantly changed. Odds ratio, 1.19, confidence interval, 0.85 to 1.68. For visits with Black patients, the odds of timely follow-up did significantly increase, 1.95. Confidence interval, 1.02 to 3.79. Conclusions. Timely follow-up for Black patients did improve, highlighting protocol interventions for more equitable healthcare. In contrast to our prior in-system study, BP Connect did not significantly improve follow-up with an across-system PC, indicating a need for direct scheduling. Future directions include piloting direct across-system scheduling. Next, we will be discussing articles from journals of the American College of Cardiology. Mandibular advancement versus CPAP for blood pressure reduction in patients with obstructive sleep apnea. Background. Hypertension guidelines recommend diagnosis and treatment of obstructive sleep apnea, OSA, in patients with hypertension. The mandibular advancement device, MAD, is an oral appliance therapy for patients who decline or cannot tolerate continuous positive airway pressure, CPAP. Objectives. We compared the relative effectiveness of MAD versus CPAP in reducing 24-hour ambulatory blood pressure, BP, methods. In an investigator-initiated, randomized, non-inferiority trial, pre-specified margin 1.5 mm Hg, 321 participants aged greater than or equal to 40 years, with hypertension and increased cardiovascular risk, were recruited at 3 public hospitals for polysomnography. Of these, 220 participants with moderate to severe OSA, apnea-hypopnea index greater than or equal to 15 events per hour, were randomized to either MAD or CPAP, 1:1. The primary outcome was the difference between the 24-hour mean arterial BP at baseline and 6 months. Results. Compared with baseline, the 24-hour mean arterial BP decreased by 2.5 mm Hg, p equals 0.003, at 6 months in the MAD group, whereas no change was observed in the CPAP group, p equals 0.374. The between-group difference was minus 1.6 mm Hg, 95% CI, minus 3.51 to 0.24, non-inferiority p less than 0.001. The MAD group demonstrated a larger between-group reduction in all secondary ambulatory BP parameters, compared with the CPAP group, with the most pronounced effects observed in the asleep BP parameters. Both the MAD and CPAP improved daytime sleepiness, with the between-group difference similar, p equals 0.384. There were no between-group differences in cardiovascular biomarkers. Conclusions. MAD is non-inferior to CPAP for reducing 24-hour mean arterial BP in participants with hypertension and increased cardiovascular risk. Cardio-Sleep Research Program on Obstructive Sleep Apnea, Blood Pressure Control, and Maladaptive Myocardial Remodeling. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Erythrocytosis is rare, with exogenous testosterone in gender-affirming hormone therapy. Context. Studies have found a variable incidence of erythrocytosis among people using testosterone as part of gender-affirming hormone therapy, GAHT. Objective. To examine the effect of using exogenous testosterone as got-on hematocrit in a large North American cohort. Methods. We conducted a cross-sectional analysis of testosterone and hematocrit laboratory values in 6,670 patients who were prescribed testosterone through Plume, a national provider of GOT. The prevalence of erythrocytosis, the mean hematocrit at predetermined testosterone thresholds, and with varying routes of testosterone administration were assessed. Results. Among 6,670 individuals, 560, 8.4%, had a hematocrit greater than or equal to 50%, 182 greater than or equal to 52%, 2.7%, and 60 greater than or equal to 54%, 0.9%. There was significant variation, p less than 0.001, in hematocrit, between different clinically relevant testosterone thresholds. T less than 50 versus T50 to 299 versus T300 to 900. 99 versus T greater than or equal to 1000 ng/dl, and when comparing serum testosterone in increments of 50 ng/dl within the target range for males, 300-100-00-00 P less than 0.001. Mean hematocrit ranged from 41.84%, T less than 50 ng/dl, to 45.68%, T 900 to 949 ng/dl. Patients on intramuscular testosterone had a higher mean hematocrit than those on transdermal testosterone, 44.96% versus 43.41%, P less than 0.001. Both route of administration, P less than 0.001, and testosterone level, P less than 0.001, had statistically significant associations with hematocrit when controlling for each other. Conclusion. While the magnitude of change in hematocrit with serum level and route of administration of testosterone was statistically significant, the absolute levels were within the normal range, unlikely to be clinically meaningful. These findings, along with the low prevalence of erythrocytosis, should help allay concerns about the use of testosterone as Next, we will be discussing articles from Chest. Ozanimod therapy in patients with COVID-19 requiring oxygen support. Background. Sphingosine, 1-phosphate receptor ligands, SRLs, dampen immunopathologic damages in models of viral pneumonia. Research question. Is it feasible to administer an SRL therapy, here, ozanimod, OZA, to acutely ill patients infected with SARS-CoV-2? Study design and methods. The prospective randomized open-label COVID-19 ozanimod intervention, COZI, pilot trial, was conducted in 3 Canadian hospitals. Patients admitted for COVID-19 requiring oxygen were eligible. Randomization was stratified for risk factors of poor outcome and oxygen needs at inclusion. Participants were allocated to standard of care or to standard of care plus OSA. OSA, oral, once daily, incremental dosage, was administered for a maximum of 14 days. Primary endpoint investigated for size effect and variance over time was the assessment of safety and efficacy, evaluated by the daily score on the World Health Organization adapted 6-point ordinal scale for clinical improvement, analyzed under the intention to treat principle. Results. 23 patients were randomized to the standard of care arm, and 20 were randomized to the OZA arm from September 2020 to February 2022. Evaluation of efficacy showed non-significant reductions of median, interquartile range, duration of respiratory support, 6, 3 to 10, versus 9, 4 to 12, days. P equals 0.34, median duration of hospitalization, 9, 6 to 12, versus 10, 6 to 18, days. P equals 0.20, and median time to clinical improvement, 4, 3 to 7, versus 7, 3 to 11, days. P equals 0.12, for OZA compared with standard of care, respectively. Heart rate was significantly lower with OZA, 65, 63 to 67, versus 71, 69 to 72, beats per minute. P less than 0.0001. However, QT and PR intervals were not affected. No severe adverse drug reaction was reported. Interpretation. To our knowledge, SRL utility in severe pneumonia has never been tested in patients. This study shows for the first time that this new pharmacologic agent may safely be administered to patients hospitalized for viral pneumonia, with potential clinical benefits. Bradycardia was frequent but well tolerated. The association between pre-pandemic ICU performance and mortality variation in COVID-19. Background. During the COVID-19 pandemic, ICUs remained under stress and observed elevated mortality rates and high variations of outcomes. Dolksprach. Knowledge gap exists regarding whether an ICU performing best during non-pandemic times would still perform better when under high pressure, compared with the least performing ICUs. Research question. Does pre-pandemic ICU performance explain the risk-adjusted mortality variability for critically ill patients with COVID-19? Study design and methods. This study examined a cohort of adults with real-time polymerase chain reaction confirmed COVID-19 admitted to 156 ICUs in 35 hospitals from February 16, 2020 through December 31, 2021 in Brazil. We evaluated crude and adjusted in-hospital mortality variability of patients with COVID-19 in the ICU during the pandemic. Association of baseline, pre-pandemic, ICU performance and in-hospital mortality was examined using a variable life-adjusted display, VLAD, during the pandemic and a multivariable mixed regression model adjusted by clinical characteristics, interaction of performance with the year of admission, and mechanical ventilation at admission. Results: 35,619 patients with confirmed COVID-19 were evaluated. The median age was 52 years. Median simplified acute physiology score 3 was 42, and 18% underwent invasive mechanical ventilation. In-hospital mortality was 13% and 54% for those receiving invasive mechanical ventilation. Adjusted in-hospital mortality ranged from 3.6% to 63.2%. VLD in the most efficient ICUs was higher than the overall median in 18% of weeks, whereas VOD was 62% and 84% in the underachieving and least efficient groups, respectively. The least efficient baseline ICU performance group was associated independently with increased mortality, or 2.30, 95% CI, 1.45 to 3.62, after adjusting for patient characteristics, disease severity, and pandemic surge. Interpretation: ICUs caring for patients with COVID-19 presented substantial variation in risk-adjusted mortality. ICUs with better baseline, pre-pandemic, performance showed reduced mortality and less variability. Our findings suggest that achieving ICU efficiency by targeting improvement in organizational aspects of ICUs may impact outcomes, and therefore should be a part of the preparedness for future pandemics. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Phase 2 trial of cemdisiran in adult patients with IgA nephropathy, a randomized controlled trial. Background: IgA nephropathy is the most common primary GN. Clinical features of IgA nephropathy include proteinuria, which is the strongest known surrogate of progression to kidney failure. Complement pathway activation is a critical driver of inflammation and tissue injury in IgA nephropathy. Cemdisiran is an investigational RNA interference therapeutic that suppresses hepatic production of complement component 5, C5, thereby potentially reducing proteinuria in IgA nephropathy. We evaluated the efficacy and safety of cemdisiran in adult patients with IgA nephropathy at high risk of kidney disease progression. Methods: in this Phase 2, 36-week, double-blind study, adult patients with IgA nephropathy and urine protein greater than or equal to 1 g/24 hours were randomized 2:1 to subcutaneous cemdisiran 600 mg or placebo every 4 weeks, in combination with the standard of care. The primary endpoint was percentage change from baseline at week 32 in urine protein to creatinine ratio, UPCR, measured by 24-hour urine collection. Additional endpoints included change from baseline in UPCR, measured by spot urine, serum C5 level, and safety assessments. Results: 31 patients were randomized, cemdisiran, N equals 22, placebo, N equals 9. Cemdisiran-treated patients had a placebo-adjusted geometric mean change in 24-hour UPCR of -37.4%. Cemdisiran-adjusted geometric mean ratio to baseline, SM, 0.69, 0.10, at week 32. Spot UPCR was consistent with 24-hour UPCR placebo-adjusted change of -45.8%. Cemdisiran-adjusted geometric mean ratio to baseline, SE, M, 0.73, 0.11. Mean, SD, change in serum C5 level from baseline at week 32 was -98.7%, 1.2, with cemdisiran, and 25.2%, 57.7, with placebo. Over 36 weeks, most adverse events were mild or moderate and transient. The most common adverse event after cemdisiran treatment was injection site reaction, 41%. Conclusions. These findings indicate that treatment with cemdisiran resulted in a reduction of proteinuria at week 32 and was well tolerated. Evaluating APOL1 genetic testing policy options for transplant centers, a Delphi consensus panel project with stakeholders. Background. Apolipoprotein L1, APOL1, variants G1 and G2, are associated with a higher risk of kidney disease. APOL1 risk variants are predominantly seen in individuals with sub-Saharan African ancestry. In most transplant centers, potential organ donors are being selectively genetically tested for APOL1 risk variants. Transplant programs have highly variable APOL1 testing practices and need guidance on essential APOL1 clinical policy questions. Methods. We conducted a Delphi consensus panel focused on APOL1 clinical policy questions, including who gets tested, who decides whether testing occurs, how test results are shared, who receives test results, and how test results are used. A total of 27 panelists across 7 stakeholder groups participated. Living kidney donors, N equals 4, deceased donor family members, N equals 3, recipients of a deceased donor kidney, N equals 4, recipients of a living donor kidney, N equals 4, nephrologists, N equals 4, transplant surgeons, N equals 4, and genetic counselors, N equals 4. 19 panelists, 70%, identified as Black. The Delphi panel process involved 2 rounds of educational webinars and 3 rounds of surveys administered to panelists, who were asked to indicate whether they support, could live with, or oppose each policy option. Results. The panel reached consensus on 1 or more acceptable policy options for each clinical policy question. Panelists supported 18 policy options and opposed 15. Key elements of consensus include the following. Ask potential donors about African ancestry, rather than race, make testing decisions only after discussion. With donors, encourage disclosure of test results to blood relatives and organ recipients, but do not require it. Use test results to inform decision-making, but never for unilateral decisions by transplant programs. Conclusions. The panel generally supported policy options involving discussion and shared decision-making among patients, donors, and family stakeholders. There was general opposition to unilateral decision-making and prohibiting donation altogether. Next, we will be discussing articles is from Kidney International Reports. Pregnancy and Family Planning in Women with Kidney Disease. Introduction. Females with kidney disease are at increased risk for pregnancy complications. Few studies have examined pregnancy perspectives of people with kidney disease. Our objective was to examine kidney patients' perspectives on family planning methods. We conducted an online survey of female patients with kidney disease from the University of Colorado Hospital between the ages of 18 and 50 years, from August to October 2022. The survey asked questions on previous and current pregnancies with kidney disease, family planning, and reproductive health discussions with their nephrologists. Perspectives on how kidney disease influences pregnancies were also explored. Results. A total of 136 participants completed the survey. The majority of participants were white, 71.3%, with a mean, SD, age of 37 plus or minus 10 years. The majority of participants self-characterized their kidney disease as moderate, N equals 57, 43.5%, with 16 participants, 12.2%, receiving dialysis. 52 participants, 38.5%, experienced a pregnancy with a diagnosis of kidney disease, which were largely planned, N equals 33, 61.1%. The majority of participants were able to conceive within 6 months, 64.8%. Nearly half of participants reported that kidney disease influenced their family planning decisions, with the majority, N equals 91, 66.5%, believing that kidney disease increased their risk for pregnancy complications. More than half of participants never discussed the health risks of a potential pregnancy, 54.0%, desire to have children, 58.0%, pregnancy prevention, 57.0%, and/or optimizing their health prior to pregnancy, 68.1%, with their nephrologist. Conclusion. Although kidney disease influenced family planning decisions, few participants had family planning discussions with their nephrologist. Lithium-associated kidney failure, predictors and outcomes. Introduction. Despite the widespread use of lithium for bipolar disorders and depression, little is known about the characteristics of patients with lithium-associated kidney failure receiving kidney replacement therapy, KRT, methods. We conducted a retrospective study using the Australian and New Zealand Dialysis and Transplant Registry, ANS data, to investigate the predictors and outcomes of patients with lithium-associated kidney failure receiving KRT. Results. A total of 437 patients with lithium-associated kidney failure were compared to 1,280 ANS data allocated controls of patients with kidney failure not associated with lithium. Patients with lithium-associated kidney failure commenced KRT at significantly older age, 62 plus or minus 10 versus 58 plus or minus 15 years, p less than 0.001, and were more likely to be European, 93% versus 68%, p less than 0.001, to be female, 63% versus 40%, p less than 0.001, and to live in a postcode with a higher socioeconomic status, SES, p less than 0.001. In patients with lithium-associated kidney failure, there were lower rates of coronary artery disease, 17% versus 37%, p less than 0.001, peripheral vascular disease, 7% versus 25%, p less than 0.001, cerebrovascular disease, 8% versus 14%, p equals 0.004, and diabetes mellitus, 16% versus 47%, p less than 0.001. There were no differences between first KRT modality, although kidney transplantation and retransplantation rates were lower, 21% versus 27%, p equals 0.008, 0.2% versus 3%, p equals 0.001, with shorter wait times to first transplantation, 20 months versus 29 months, p equals 0.02, in the patients with lithium-associated kidney failure. Rates of at least one rejection episode was comparable, 21% versus 22%, p equals 0.85, between the two groups. In addition, there were no survival differences, regardless of KRT modality between the two groups. Conclusion. Lithium-associated kidney failure represents a unique cohort, which is predominantly older, female, European, with a higher SES, and less comorbidities. Despite this, there are no differences in survival. Given the lower rate of transplantation, barriers to transplantation need further exploration.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.